Hello everyone, Happy New Year and welcome back. Welcome to Your Health, Your Choice. I am Dr. Roopnarine, and on tonight's program, we'll be continuing our discussion on the COVID-19 pandemic. In the studio with me tonight to provide his own personal insights is the very esteemed Professor Hari. Professor Hari is the Professor of Anesthetics and Critical Care at the University of the West Indies. Professor is also the Director of Graduate Studies and Research at the University of the West Indies. As usual, our numbers should appear at the bottom of your screens, and we should do our very best to address your questions in the final segment of the program. So, welcome back, welcome to 2022, and let's get the show going. Professor, nice to have you.
Thank you, Robin. Thank you for having me.
All right, thank you for coming out. I know you were on call last night in the ICU unit.
Yeah.
All right. Professor, when you were last here, which was the middle of December, we had a surge of Delta infections in the country at the time.
Yeah.
We are still going through a massive surge of Delta infections. The mortality rates are high.
Yes.
On the horizon, obviously, is an Omicron tsunami headed this way to Trinidad and Tobago.
Yeah.
If you can prepare us, Professor, what do we know about the Omicron virus or the Omicron variant? What is going to happen in Trinidad over the next few weeks? And how can we prepare both as a people and as a country for what is about to happen?
Okay. Now, the Omicron variant, as you know, was first detected in South Africa. When currently we can do fingerprinting techniques and the ancestry of virus, right?
Yes.
So how they evolved and how they mutate and so on and so forth. So it was speculated that in South Africa, when there is an immunocompromised person, okay, HIV affected person or somebody who is unvaccinated, when the virus is not be able to be cleared from the system for long, that happens in unvaccinated people.
Yes.
So that's the main reason we are pushing for vaccines. So the vaccinated people clear the virus faster. But when the virus stays in the system for a longer period of time, it has plenty of opportunity to mutate itself.
Okay.
So again, as we all see that, it's a race. So there are plenty of discussions going on in the scientific circles. I read a lot of evolutionary biology regarding the Omicron virus. So the Omicron virus, actually, if you see the ancestry, it has taken up some of the parts from the common cold virus.
Wow.
So some of the evolutionary biologists are now comparing it to something called, we have another coronavirus called 229E.
Okay.
Which and then even the respiratory syncytial virus, you know about it. Mm-hmm. Children get acute cold and acute respiratory infection, and it just goes away in 2-3 days. It reinfects. So a person who is a virologist who is actually studying the 229E virus or the respiratory syncytial virus, they have seen that how the virus evolved and just became a very least virulent virus.
Okay.
So we as children got infected by the respiratory syncytial virus when we were very young. So we develop immunity, and then even when we get reinfected, we don't get much of an issue with that.
Correct.
So some of the evolutionary biologists are saying that this is the first step. Omicron may be the first step in the whole SARS-CoV-2 evolutionary biology towards weakening of the virus.
Okay.
But the practical clinical data which is coming out are conflicting. The one article which was published last week in Journal of American Medical Association from South Africa, they categorically said that the intensity of the infection, the virulence, the number of hospitalization, the number of people who are requiring ICU are really, really low.
Okay.
Compared to the Delta.
Yes.
And with the advantage, the evolutionary advantage of Omicron, it is inevitable that the Delta can be replaced by Omicron. But if the trend of Omicron is like this, that the virulence is low, it is good for the world.
Yes.
Unfortunately, the clinical data which we are getting from South Africa is conflicting with what we get from UK, England, as well as from Denmark.
Okay.
Denmark still they reported a very high and almost on par, or very little difference between the Delta and this one with respect to hospitalization.
Okay.
But mortality was still less.
Okay.
That is one good thing.
Right.
Consistently in all the places where Omicron is spreading,
yes,
the overall mortality is less. Okay. I would have told you last time that the average mortality, case fatality for COVID, SARS-CoV-2, ranges 2.5.
Correct.
We are in 3. Yes. 2.5 is the global average. Now the Omicron is even less than 2.
Okay.
Yeah, somewhere there 1%. So far is very, very, very very minimal mortality wise. But the hospitalization is increasing, and the other little scarier part is that as I told you, the respiratory syncytial virus can infect children. Mm-hmm. Same way, Omicron also starts infecting the children.
Okay.
The other major thing which we have to be a little more careful about is that the efficacy of the existing vaccines, which were in the 90s and 70s and 80s, 80% efficacy, it is coming down. There are some sporadic reports that that there can be an immune escape. It can evade the current vaccine, although it has not been completely established. Still the Pfizer vaccine and the Moderna vaccine are effective against, and they tested even the Johnson & Johnson vaccine are reasonably effective against the Omicron. Okay. Now, when you see the vaccine efficacy, if you study that, the FDA or WHO, 55% is the threshold value.
Right.
Anything above 55%, they will approve of it. Okay.
Right.
So they study 40,000 patients. Yeah. 20,000 patients get vaccine. 20,000 patients do not get the vaccine. Right.
Yeah. So
let us reduce that to 100.
Yeah.
In 100 people who got the vaccine, if the vaccine is able to prevent serious illness and mortality in 55 or above, okay,
yeah,
or even transmission,
yeah,
so then you get the approval. The problem with the other viruses like HIV and dengue and all that, they mutate very fast, and that is why we are unable to reach that 55% threshold.
Okay.
So HIV vaccine was tested last month and it was only 33%. So it cannot work that way. Right. But now we haven't reached to that level of below 50% with the Omicron variant yet. Right. But the problem is that the more we leave people unvaccinated because of so many reasons, which we will discuss later, the problem can happen that it can have further mutations and further, and so we are going to go into the cycles of multiple waves of this pandemic. Okay. So that is why we are saying that we do everything, including vaccination, as an armamentarium to cut short this pandemic. So the one another very, very recent study which is published, which is not peer reviewed yet, but there is a separate journal where they publish preliminary data. So in that MedRx review, right? In that particular journal, I saw a South African researcher about Omicron. Omicron has a very good property of developing immunity even against Delta infection. Okay. So if a patient gets a reinfection with Delta, it's not possible if they would have had the Omicron. The Omicron antibodies are effective even
against you protection against
Delta too.
Right.
So that is one good thing.
Right.
There are so many studies going on now, laboratory studies and clinical epidemiological studies. The only thing I wanted to say, it's very, very, very early in the game with Omicron.
Right.
Whole SARS-CoV-2 itself is emerging infectious disease. We are unable to predict. Right. But the Omicron is extremely new
Yes.
So we need to get much more information before categorically saying that yes, okay, absolutely, we don't need to worry about it. But at this point of time, we need to worry only because of the surge capacity.
Right.
Because the more and more people get Omicron, because they are not what we call as the transmissibility power has increased fourfold.
Right.
With the Omicron.
Is the Omicron virus, Omicron variant, sorry, given people respiratory symptoms such as what the COVID gave people, shortness of breath, and that sort of lung embolism, lung fibrosis.
One good thing good thing with the laboratory data, and they have done it with animal studies too, with Omicron. Omicron has the propensity to stay in the upper airway.
Right.
And they compared the Delta and the Omicron with respect to the lung tissue.
Right.
And Delta is much more affecting the lungs, but Omicron stays right in the upper airway.
Right.
It is not affecting too much of the lungs, and that is why they are hypothesizing that it may not be as dangerous as the Delta.
Right.
So, but if that trend continues, that's good. Omicron, as such, now is it is a mix of a common cold virus and the SARS-CoV-2,
right?
And that is where it took all the nucleotides, right?
Okay.
So it stays in the upper airway,
right?
There is clear evidence for that.
So it's almost you speak almost optimistically that Omicron is on its way to Trinidad because it's less lethal so far.
So far it is less lethal, but it can, again, I tell you, the hospitalizations is not reduced in certain countries.
Right.
So when they have the fever and the sore throat and then with the current panic of everybody, then shortness of breath, and they just get into the hospital. So hospitalization is still on the higher side in certain countries. So only in the next 3-4 weeks we will get very good data to compare Delta variant with the Omicron variant.
Right.
And in Trinidad now, according to the current statistics, is 75% is Delta, 25% is Omicron, which can replace.
Right.
Omicron can replace Delta. That is inevitable because new variants with a higher transmissibility power always takes over.
Okay.
The virulence of the organism, the lethality associated with the organism is what is now in question. When we get much more data in the next 3 to 4 weeks, we will be able to know whether indeed Omicron is a better variety or not.
Right. Can the virus mutate from a less lethal form, for example, Omicron, to a more lethal form? Or once it goes less lethal, does it continue along that pathway? Yeah,
that's a very good question because the evolutionary biologists have studied most viruses, right? Majority of the viruses, 90% of the viruses, when they actually mutate, they actually lose their virulence.
Okay.
Majority of them.
Okay.
But there is a possibility, theoretical possibility. The SARS-CoV-2 is behaving completely different.
Right.
So there is a possibility that it can take some other segment from some other virus and can increase the virulence.
Okay.
But it is only a theoretical possibility, but in a practical experience, it's always on the decline.
Right.
So if you see the mutating capacity of SARS-CoV-2, it is half of the ability of influenza virus. Okay, so we are not still there.
Yeah.
Influenza virus mutates much more than the SARS-CoV-2.
Okay.
And SARS-CoV-2 is 1/4 of the HIV virus.
Okay.
HIV is 4 times more than the SARS-CoV-2.
Yes.
Influenza mutates twice as SARS-CoV-2.
All right.
So SARS-CoV-2 is still, we are fortunate that it is not mutating that fast.
Yes.
So based on the biology and the evolutionary biology, we are hoping that it will lose its virulence slowly, and it will become like a common cold virus or a respiratory syncytial virus. If it comes that way, that is a good thing.
Is this sorry to interrupt, Professor, is this our way towards natural herd immunity?
Exactly.
Now, this is a question I have, because if someone gets infected with the Omicron, they develop antibodies.
Yeah.
So this is natural herd immunity that we're always talking about from the start.
Yeah.
It's either natural or we acquire it through vaccination. Is natural herd immunity a long-lasting herd immunity? I mean, can people get repeated illnesses
Yeah, that is a possibility with the SARS-CoV-2, because unlike measles and smallpox and polio and other viruses, respiratory syncytial virus repeatedly infects people.
Right.
So there is a possibility that they can be reinfected, but if it is just reinfection and just a sniffles and 3 days common cold, and it won't be a big problem.
Right.
But one another thing is that with the vaccination, with the T-cell response, it can be a long-lasting immunity, and that is what the immunologists are speculating at this point of time, that it won't be exactly like the respiratory syncytial virus, because we don't have a vaccine for that. We don't have a vaccine for common cold virus, but we do have vaccine for SARS-CoV-2. So far 4.5 billion people have had the total doses in the world is 8 billion. 8 billion vaccine doses have been given.
Right.
So we have enough, vaccines given, despite the fact that there are many countries in the third world, in Africa,
who haven't had
it. And that is the reason why the virus is mutating.
Right.
So if you would have had the vaccine across the world, still as I told you, already the mutating capacity is lower than influenza.
Would have been out of the pandemic.
Correct.
All right. So, Professor, we just want to take a little break, and when we come back, we're going to discuss a little bit about your skill set, which is the ICU care.
Sure.
All right, guys. So, we're going to take a little break, and you can send in your WhatsApp messages from now, and we'll address it in the final segment of the program.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest. You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance. Explore the many ways to make your harvest right for you. Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture. Sponsored by Munich Home and Garden, the Agricultural Development Bank, and the Plant Doctors.
Our lives feel so different now. School is more intense, work deadlines are shorter, and traffic takes hours every day. Despite all this, I want my family to have wonderful meals and spend time together, just like I did growing up. In my house, it's only Caribbean flavors. I spend less time at the stove and more time with the people I love. Quick, easy, delicious. Caribbean flavors.
Munich Home and Garden specializes in hardware, paint, home decor, tools, agricultural supplies, pet supplies, car accessories, appliances, and much more. Located at Val Park Shopping Plaza, Atlantic Plaza, Point Lisas, and Eastern Main Road, St. Joseph. Shopping comfort with our well-secured outlets. Call us at 663-5163 or visit the Munich Home and Garden Facebook page or www.munichtT.com. Munich Home and Garden, where we make shopping a fun experience.
At Extra Foods, we care for you. That's why we always have the widest variety, the best prices, spacious aisles of total convenience, plus clean, safe surroundings. Let us care for you. Extra Foods, always extra for less.
All right, guys, welcome back. We're here with Professor Harry, and we're discussing some personal insights into the COVID-19 pandemic. So, Professor, let's get straight to your field.
Yes.
And I suppose the topic of the hard question is, Trinidad and Tobago's COVID mortality rate is very high.
Yes.
Some people are saying it's amongst the highest in the world, right?
John Hopkins came with a graph, which at one point of time it was.
All right.
Yeah.
The obvious finger is pointing, or is this a red flag that something is going wrong in our ICU departments? And but more importantly, can you tell us what is the treatment protocols that happen in the ICU departments? What medications do our patients get when they get into the ICU department? And is there something, are we following international best practices? Are we getting the same, why are we not getting the same outcomes as other countries, for example? Professor,
okay.
Please, it's a really loaded question, but
yeah,
it's a hard question. It must be
know,
asked.
yeah. The mortality, ICU mortality, ranges from 2.5 to 3, right? I mean, it depends on many factors, including the patient factors and the ICU factors. So there are, that's the major thing which you have to understand. Now, we follow the WHO protocols, the treatment guidelines, and that is what Ministry of Health has been, very strict about, including the vaccines. Everything we do with the WHO protocol. Now they can say that at the primary care level, we haven't given ivermectin, which I told you that ivermectin is equivocal and there is no clear benefit. At the ICU level, now what we do is that we have to now start steroids.
So the patients get steroids.
What happens is that when a patient develops COVID, so the lungs get affected, the oxygenation gets affected. But because in all other hypoxemic patients, that means oxygen low level patients, they start becoming restless, heart rate goes up, and they can't breathe, and so on and so forth. But in COVID, something called a happy hypoxia happens.
Happy hypoxia?
Yes.
Okay, can you explain that?
That is actually, so when you put in a pulse oximeter, it will be like in the 80s. But the patient will not be breathing fast, will not be restless, will not be perspiring, will not be having air hunger. All these things are signs, clinical signs of what we call as hypoxemia. That means low oxygen in the blood. That does not happen in COVID. So what happens in the home front, when people stay at home, they feel that they are fine. All right. So people may not even have a pulse oximeter to monitor. All right. So what many people stay at home, and the major issue is that the moment they start having respiratory issues, we need to start them on the steroids, dexamethasone.
Can I just stop you there? Is there are you saying that there's a sort of dichotomy between what the pulse oximeter the patient has and how symptomatic
they behave?
How they behave?
Yes, that is what is the happy hypoxia.
So that's scary.
Yeah, that is scary. So that is why people do miss it, and we are unable to start the steroid at the right point of time. And already inflammation sets in, and what we call as an acute respiratory distress syndrome develops. The whole of the lung parenchyma is infiltrated with the COVID. It becomes fluffy, and then the oxygen is unable to go in. And then it affects all other systems, including hematological system, blood clots, bleeding, and then once the sepsis goes in, then you get multi-organ failure. Many people, I see, COVID patients, right? Many of them get renal failure, acute renal failure. And then the hepatic failure, liver problems comes in. But the common thing is the renal failure. So now what happens is that when we catch patients at a little later stage, whatever we try to do will not bring them back. All that we can do in ICU, the major thing what we do is organ support. A critically ill patient has multiple organ failure. Now, SARS-CoV-2 affects the lungs. There is no oxygenation. So when the oxygenation goes down and down and down, we start with the simple face mask, and then go up on the face mask, and then go into what we call as a non-invasive ventilation with a mask. And then if the oxygenation is not better, then we put in a tube down the throat and give the ventilator support. So once they go into that, they become really critically ill with multiple problems. The blood pressure can go down, hemodynamically they can get compromised. Then they can have acute renal failure, which we commonly see. So when we have all these systems affected, now what we can do is only the organ support we can do. And then we can give some pharmacological therapy. So now what WHO has given is that we had this repurposed antiviral drugs like remdesivir, is not very effective according to WHO. There are some studies which were published in New England Journal Medicine that they had a very slight advantage in one study. Another study did not show clear advantage. So WHO has not clearly recommended remdesivir. So we don't use the remdesivir. We use the dexamethasone for sure. We use the methylprednisolone, which is a steroid. We use that. We give organ support. When they develop renal failure, we give them the renal replacement therapy, hemodialysis, or what we call as a continuous veno-venous hemofiltration,
and antibiotics,
CVVH.
I suppose, as well.
Antibiotics is when they are in the hospital setting, when there is a super added infection with bacteria, which happens always. Because they are already sick and immunocompromised, so we are loaded with so many bacteria. So the bacteria come into play, into the the sepsis, and then to counter the bacteria, we give antibiotics, which are good antibiotics. We do have it. Now the other one, in some other countries, we do have the monoclonal antibodies, which are really expensive. We do have the repurposed monoclonal antibody, which is the tocilizumab, which is still available, but we actually select patients who will be really benefited from the tocilizumab, and that is where we use it. Because we have the tocilizumab not for COVID actually. We have it for rheumatic conditions. Rheumatoid arthritis and those rheumatic conditions. So, but we use that, I mean, because it's a repurposed drugs, and there are some studies which showed some benefit. So we do get tocilizumab here, which is expensive, very expensive. Almost like $250,000 per vial. So, but we do have it. But we selected patients who we know that will be benefited. Now, what happens with the mortality is because they are already into when they come in, they are in extremis. They have multiple organ failure.
This is when they come into the ICU.
Yes. They have multiple organ failure. So then
is that a result of people presenting late to hospital?
That is one of the reasons, and there are comorbidities. And they are very old patients, and we try everything possible, but only one thing I would say we can improve a little bit is the human resources. But what happens is, I'm in this country for more than 2 decades now. Now, since the time I came, our ICU capacity has not much increased. When I was doing residency in the 90s in India, in my medical school, we had a multidisciplinary ICU which we managed, surgical ICU which anesthesiologists managed, pediatric ICU, coronary care ICU, neuro ICU, So almost 6-7 ICUs in one hospital. But here we have one ICU per hospital, and we have to manage all the elective and emergency trauma, you name anything, everything comes into that. And we have been trying to get the ICU beefed up according to the bed strength. If you see San Fernando Hospital, it's 1,000-bedded hospital. If you see Eric Williams, it's 500-bedded hospital. So there's a proportion of ICU bed for the services we offer. I would say it is not still adequate, but we need to do that on a long-term basis, but not in the context of COVID alone. I can tell you that, because developed world, you saw what happened in US, we saw what happened in UK, what happened in Italy. Was overflowing. Surge capacity was there. ICU is, every single ICU practitioner knows that ICU is not the solution for COVID. It's in the primary level, in the in our public health regulations, and that is where we have to follow. We have to vaccinate. We have to follow the public health guidelines, and that is where we are.
Can I just ask a question kind of relevant to doctors and the patients? You're saying that patients are presenting too late to the hospital.
That is one of the reasons.
And one of the reasons. What is your personal opinion? Like in Trinidad, a lot of people purchase like oxygen concentrators and oxygen cylinders to do treatment at home. I heard it being mentioned in one of the news reports, like doctors treating people at home as well. What is your opinion about these oxygen concentrators and oxygen tanks for treatment of patients at home? Because it is happening. It
is happening, but the natural progression of COVID is that,
is it risky business?
It is risky. That's what I'm trying to say. The natural progression of the COVID is that if they are unable to heal themselves, when they start actually requiring oxygen,
Yeah.
It's absolutely unpredictable how much they will require or whether they will go into the ICU.
Right.
So that is why in all my talks and all my advice, I tell them that you can have home treatment only when it is mild to moderate.
Okay.
The moment you see the oxygen starting coming down, and when you have shortness of breath, it's better to go into a hospital.
Right.
Now, what happens is that I know that because of the surge capacity, because they have to be in the tent, they have to be in the biocontainment area before they get into the parallel healthcare system. Many people are vexed with that, and they think that, okay, we will arrange something at home.
Yeah.
We will ask some doctor to come and give some treatment. It happens, but it is a risky business, because I'll tell you, the moment we bring them into the general ward, they may require 4 liters per minute of oxygen with a small face mask.
Right.
The next day, they may require 10 liters, 12 liters with what we call as a Venturi mask.
Right.
And then, when many people deteriorate to what we call as a high flow nasal cannula, which is 30 to 40 liters per minute,
right,
which no oxygen concentrator will be able to give,
right,
and even the oxygen tanks, if they have it,
right,
30 liters is not possible there.
Right.
It is only possible in the hospital system.
Right. So what I get in there is that you're saying it's a precipice once people start getting sick.
Yes.
And it's a quick precipice towards the ICU unit.
Yes.
And that's why everyone is telling the public, when you feel sick and when you get the shortness of breath, make your way to the hospital. We want to get you early. Do not delay treatment at home.
Correct.
Messing around.
Correct.
Basically.
Yeah.
All right. Other than the late presentation, why is it that our mortality rates are so high?
Okay, so the one area where we can improve, as I told you, is the human resources.
Yes.
Because despite...
So not only specifically to the ICU, but why is it high in general?
No, but many people die in the high dependency unit as well as in the ICU, which is not unique to us, I must say that.
Right.
And I read a latest published article from UK, and they compared from June to September and October to January, the mortality in HTU and ICU in UK. It has gone from 16 to 24% in this last 3 months.
Right.
So everywhere it is increasing. I'm not saying that it is unique to us, but my issue is that here we do not, definitely we can do a little better with the number of nurses available, number of doctors available, because the critical care, as I told you, is multi-organ support.
Yes.
So when it is multi-organ support, there should have 1:1 nursing. And currently, in certain, when there is a big surge capacity, they have to take care of 6 patients. One nurse, 6 patients. What they can do? We can't do anything. So I must say that
job so far,
they are doing a good job, but it is not the optimal care.
Of course.
When in a regular ICU, we never compromise on the 1:1 care. Only if the acuity comes down, that they are not requiring much of a organ support, but they need some just critical care monitoring and observation. That's the acuity comes down. We actually see 1:2.
Okay.
One nurse takes care of 2 patients.
Okay.
But 1:1 is the standard for any critically ill patients who requires multiple organ support.
All right.
Which is not currently it's not possible because we are short of critical care nurses.
All right. So what you're basically saying is, yes, we are following WHO protocols in our hospitals. In the ICU.
In pharmacology.
In pharmacology.
Yeah.
The trend of high death rates over the last few months has been a global trend.
Yeah.
Right? We are not necessarily abnormal compared to others. And like people have always said from the start, I think this is what I'm getting from you, is that COVID-19, this pandemic, exposes the systems that you had in place before the pandemic. And I think that's what has been shown up now.
Exactly.
And as we have always known before the pandemic, that we had inadequate nursing.
Even at that time, we did not have a beefed up ICUs.
Right.
And now when we have a surge capacity which is really overwhelming, we have to use all possible places as ICUs, and then 6 patients on ventilator and 1 nurse taking care.
Okay. So that's where it's as Trinidad and say how you start is how you finish, basically. Professor, I really need to address the vaccine hesitancy, right? I mean, it's kind of shocking to me too. Like in my clinic today, a large number of the patients that I met were unvaccinated.
Yes.
So we're going to start a little discussion now. The majority of the patients, I think the reason that I've ascertained over the last 2 years is that there's a great distrust. There's a lack of trust.
Mm-hmm.
And I think the patients or people in the public, they don't trust big pharma.
Yeah.
And they don't trust politicians. Right? And I think those are the two groups of people that sort of led the vaccine campaign initially. Now, Professor, you have a PhD in health economics.
Yes.
You're a man well versed in the economics of pharmaceutical industry as well. Big pharma is making billions of dollars during the pandemic.
Yeah.
It has always been an uneasy marriage between pharmaceutical companies and healthcare.
Yes.
Even before the pandemic, it was always an uneasy marriage.
Yeah.
There's profit in healthcare, and our patients sometimes become suspicious of that, and they're suspicious of big pharma. They're seeing one vaccine, then two vaccines, and then you go, now it's 3 vaccines, some countries have 4 vaccines. After the break, what you're going to take now, I'd just like to hear your opinion
Yes.
on whether, on this whole issue, and can we really trust big pharma to be a companion to us humans in the fight against the virus?
Okay.
All right, so we'll take
Definitely.
a short break.
Definitely.
All right, guys, so we'll take a 2-minute break. Professor is going to gather his thoughts, and we'll be right back to you.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen. Stacy will be packing up her trolley at Prasad's The Food King supermarket and making a special stop at the Chadak Lane. We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients. Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
All right, guys, welcome back. Professor, where we left off there was the big pharma.
Yes.
Uneasy marriage with healthcare,
Correct.
pandemic. They're
Correct.
making a lot of money. Can we trust them?
Okay,
What do you say?
I must say that the major reason I went for the PhD in health economics is the commercialization of medicine.
Yeah.
Yes, there are a lot of issues with the commercialization of medicine. You know, the monoclonal antibodies and all the big pharma are competing with each other for vaccines, for monoclonal antibodies, and and making as much as money. But I must say that the conspiracy theory that they will not be on the human side, and they will be only on the money side, and they will make things favorable for them to sustain the pandemic is not correct.
Okay.
That is not correct.
Okay.
Everybody wants the pandemic to end.
Right.
All right. So and that is for sure. But as the pandemic is here, everybody is trying to make as much as make hay while sun shines.
Right.
They are making money. I'm well aware of that.
Yeah.
But the conspiracy theory that they are doing this only to they are just doing that for making money, and it's not with the benevolence in their mind is not correct.
Okay.
And the mRNA vaccines have really helped. I will tell you that the current statistics, I mean, a conservative estimate is that the 2021 vaccination would have prevented 575,000 deaths in US alone.
Right.
US alone. Globally, millions of deaths have been averted by the vaccination.
Right.
There is no doubt about it.
Right.
Because when you see the number of people who are dying in ICU who are vaccinated versus unvaccinated, you can very well find a very good mathematical model as to how many lives you would have saved with the vaccine.
Okay.
And it's astoundingly high.
Right.
So that is why we, as a science person, I will still, with all its pitfalls and shortcomings, because the new variants coming in, the efficacy going down, all that stuff is there with the vaccines.
Yeah.
And then the big pharma is coming in to produce a new polyvalent vaccine, which is good in one way, but the thing is we are racing between the virus and the big pharma are conducting a race.
Right.
But eventually we will win. But my thing is, at this point of time, do not go by conspiracy theory that the pandemic is sustained by something for money making. It is not that way.
Of course not.
But the vaccines are really, really effective in preventing mortality.
Right.
Not necessarily preventing the transmission of infection. Okay,
right.
The transmission may be there, but there is definite
right.
science in preventing mortality.
All right, no, that's just important to put that to the public, and that is a real concern out there. So, Josh, I think we have some questions, some calls. You can put them up, please. Yes, please. Anytime.
So the ICU, I was on call last night.
Go ahead.
So the 90% of the people waiting to go into the parallel healthcare systems are unvaccinated.
Right. Right. How big a role, Professor, how big a role did the accuracy and cost of tests play in the lack of control of the spread? How big a role did accuracy and cost of
Okay, so
it's a fairly reasonable question.
yeah, many countries many countries which did massive testing, like Singapore, South Korea and stuff,
Yeah.
they were able to actually prevent spread. There is no doubt about it.
Right.
We actually we can beef up some more. There are the two types of tests, which are the antigen tests and the PCR tests. PCR is a bit more cumbersome, laborious. It has to go to the public health lab or the private lab, which have been recognized by the Ministry of Health,
yeah.
and many other institutions. They do have the antigen. If you have a good company like an Abbott or a Roche or a very good company which has a 99% sensitivity to pick up this one, they can be used to actually as a screening for so tests are important, definitely. There is no doubt about it. We haven't had the number of tests which we can do, and even in the for the PCR, we have the Trinidad Public Health Laboratory and the virology the labs in the major hospitals,
right.
And we do have some private labs which are doing the PCR. But the public health system for a common Trinidad citizen who cannot afford $1,200, they have to wait.
Okay.
Yeah.
All right, so let's get some more questions there, Giles. With the research showing that Omicron is less virulent, does this mean that we will be seeing a move to the populations becoming more tolerant? Is it possible for new and more virulent strains to emerge again? I think you answered that.
I answered, but I will reiterate that it is
a good question.
It's a good question, and we will be able to categorically say only from the clinical data, with respect to ICU admissions, hospitalization, ICU admissions, and mortality.
Right.
Which we have only small research papers out of South Africa,
right,
and some out of UK and England.
Yeah.
But data is being collected now.
Yeah.
So over the next 3 to 4 weeks, we will be able to categorically say that yes, it has come down,
right,
and it is not as dangerous as we thought.
Right.
So, but until then, we have to wait.
Yeah.
And currently, as it stands, the hospitalizations with Omicron are going up. Okay. So we have to be a little cautious on that.
All right. Cool. Giles, for the future, are you aware if research is being carried out on improving these vaccine tests? I suppose vaccinations. Little is said about this.
Which one? The vaccine test meaning?
No, vaccination. Is research being carried out to improve vaccination? I think that's what I mean.
The vaccines?
The vaccines.
The vaccines?
Yes.
Currently, as it stands, 236 candidate vaccines are being there.
Wow.
Out of which 40 vaccines are being at the phase 3 trial. Okay, at the almost like approval stage.
Vaccines again.
And 194 are in the preclinical this one. So there are the whole idea of this vaccine thing. Everybody is thinking that we just rushed it. We did not. It went through every single phase like any other vaccine. The only reason it came out very fast is because everybody pumped in money. And I'll tell you about the classic example of Ebola. Ebola was first recognized in 1974 in Africa. But because it did not come out of Africa, It was not a white man's disease.
It was stuck in Africa.
It was in Africa, so nobody bothered.
Yeah.
So you know that WHO has still a list of neglected tropical diseases.
Yeah.
It's called neglected, quote unquote. I'm ashamed to say that, but that is what that is how the pharma companies work there. That way, that is how it is. Now, when the Ebola came in 2016 to US, the shores of the US, immediately, they started pumped in money, and within 2 years we got a vaccine for Ebola.
Yeah.
2 years we got an vaccine Ebola. So it's money.
Right.
Again, you asked that big pharma.
Yes.
So that is big pharma depends on money.
Right.
So now what happened with this current scenario? Because the whole world was paralyzed.
Yeah.
They pumped in European Union, US pumped in money.
And get it done.
But the thing is, we did not scientifically compromise any tests.
Okay.
We went through the preclinical tests, phase 1, 2, 3, everything.
Right.
And then we got an emergency use authorization only because we didn't have the time for a full authorization.
Of course.
So full authorization happens only after so many vaccine doses have been given and we have seen the safety data, which happened with the Pfizer.
Yeah.
And they gave the full this one with the FDA.
Okay.
So emergency use authorization is not because we are doubting or anything.
No.
We didn't have the time at that time.
Of course, people were dying.
Yeah.
And all right. So, Jazz, do you have any other more questions? Considering the problem with the efficacy, should we in Trinidad be waiting for 6 months to get a third jab, especially those with Sinopharm? Good question.
Very good question.
In the newspapers and stuff.
Yes, actually, my personal opinion is that, the 6 months for Sinopharm can be reconsidered by the government. Yeah. Because we did have some data from Brazil and Indonesia and some other countries where they had the Sinopharm, where actually there were mixed this one and there were some breakthrough infections, a high amount of breakthrough infections, which we are seeing here too.
Yeah.
But the thing is that it is still not. I wouldn't say that it is completely ineffective.
No.
The efficacy has come down.
Yes.
So with the available data now, with the overall available data with the Sinopharm, Sinovac, all other this one, and because we are getting the other vaccines like the mRNA vaccines, which are definitely considered to be better as a booster.
Yes.
All right. I think the FDA went with the available studies and the antibody titers and so on and so forth for 6 months.
Yeah.
But there were some governments like the UAE, the United Arab Emirates, they did not wait for anybody.
No.
So they thought that, okay, I will go for a Pfizer, and within 3 months they gave another booster. So the political decision has to be made, but I cannot say about that. Yeah. But because it is complex, because it involves legalities
and supplies,
so many things and all
supplies and so on. Jazz, have we been seeing any incidents of long COVID here? Is it the symptoms that persist or the virus that stays infecting the system? Good question. What is the
virus gets cleared up after COVID, but the symptoms, because they go and affect the various systems, the systems take time to heal, and because of the systemic inflammation, that's what happens with our sepsis. All systems have inflammation, including the central nervous system. So that is the systemic inflammation, and the residual effects of the systemic inflammation causes the long COVID symptoms.
Right.
We are starting to see some lung problems, some CNS problems. I mean the central nervous system problems. It's already because we are 2 years into the pandemic, so we are seeing it. We don't have the data yet. We are collecting the data, but we don't have the exact data. But we are starting to see long COVID. Not because the virus is staying, but because of the residual effects of the systemic inflammatory response.
All right. With someone who gets infected with Omicron, would they also have long COVID symptoms?
That is a question to be answered only by time. This is why I'm saying, because if the virulence is not much and it stays within the upper...
The reason I'm asking this question is that I want to sort of dissuade people from not getting vaccinated, thinking that they could get the Omicron.
No, but
But vaccination sort of prevents you from getting long-term COVID.
Exactly. That's
so I think that's one of the greatest benefits of vaccine.
Yeah.
As we meet variants that are less lethal,
correct,
we still need vaccination. I mean, it's a great benefit not to get long COVID.
Yeah. The vaccine induces the B cell and T cell immunity so that the systemic inflammatory response, because the virus replicates and goes all over the body and affects all the systems.
Right.
So that will be reduced because we clear the virus as much as possible.
All right. So let's get our next question, Giles. We have a few still. What is the safest vaccine the doctor would recommend for a cancer patient?
Okay, there is absolutely no this one that only one vaccine is safe for a cancer patient. A cancer patient will be on immunotherapy, immunosuppressant therapy, because their immunity will be they take the chemotherapy, right? Yeah. So they are much more prone for severe COVID. Yeah. So if available, we don't have the Moderna. Yeah. According to the efficacy, Moderna has the highest efficacy, then Pfizer, then comes AstraZeneca, Pfizer and AstraZeneca, then comes Johnson & Johnson. Yes. This is in that order. Right. Moderna, Pfizer, AstraZeneca, Johnson & Johnson, then comes the Virion vaccines like Covaxin and Sinopharm. Yeah.
All right. Next, please, Giles. If you are infected but you don't know or don't have symptoms, and you take the vaccination, what may be the reactions?
There won't be any reactions. It will actually enhance the clearance, virus clearance. Right. But it's no guarantee that the vaccine will be helpful in preventing a serious disease at that point of time. Right. Because for the full immunity to develop after vaccination, it takes 2 weeks.
Okay.
So it won't cause a reaction.
Okay.
Definitely no reaction. All right. If you are asymptomatic, you take a vaccine, it's okay. Absolutely no problem. All right. But there is no guarantee that the vaccine will protect them.
Okay.
Yeah.
Okay. Giles, I would like to know why a person have to wait so long for a COVID test result from the health centers.
Okay, I think we discussed that, but definitely, with the surge capacity now, with so many people waiting for a test,
been clogged up.
Yeah, everything is clogged up, and even for elective surgery, in operating room, we have to do the PCR to get into the theater. Right. For getting into the admission ward, you have to get PCR. Right. So there is really a surge capacity. Right. So COVID came now, but people do have all other diseases, stroke, heart attacks, COPD, so many things are happening and people want to come into hospital, right. Non-COVID patients, right. But they all must be tested to get into the hospital, right. And surgical patients must get PCR to get surgery, right. So, and we have one lab per hospital, and many of them have to go to public health CARFA lab. Right. So that is why we have the surge capacity is what it is. Right. So the basic thing again is that how much ever we can prevent spread is what is important.
All right. We'll take one more question, Giles. I had my 2 doses of Sinopharm vaccine. I also got my booster vaccine, Sinopharm. Can I take another booster of Pfizer?
At this point of time, it is not recommended that way. A 4th dose has not been recommended even by FDA or WHO. Right. People just go and take, because they want to be doubly sure, triply sure. Some people quadruply sure. Yeah. They go and take it without telling that they had a vaccine. Right. I can't recommend that officially. Right. Yeah. But the 3rd booster itself is good enough. Right. But people do many things. I read somebody in Italy went and took 6 vaccines. 6 because he was so paranoid about COVID. Yeah. So that's the other extreme of it. So we should be balanced.
All right. Yeah. So Professor, we have 1 more minute in the program.
Sure.
I'll just probably give you the last word, but I would like the majority of the ICU staff in this country, the anesthetists, they would have passed through your hand as their professor. A lot of them would be your former students. Yes. They're probably going through the toughest time in their professional career.
Exactly.
That the world of medicine will ever have seen.
Exactly.
what words of advice would you give to your students who are now the front line of healthcare in the ICU? What words of wisdom would you have for them?
I did talk to many of them. I know how they are feeling. You know, people are in the parallel healthcare system, seeing patients, you know, dying in front of their eyes. They are unable to even. Some person told me that, you know, they cross the level of PTSD. They don't have any more stress disorder, post-traumatic stress, because people are dying like, you know, every day. You know, I go into the ICU from morning 8 o'clock, within the rounds, three people die within the 8 to 12. So it is really difficult for them, and they have to be in the, you know, in the ICU with the PPE and taking care of them and running here and going there and, you know, resuscitating and trying as much as possible. But they are definitely doing a good job, and I don't have a problem with that.
Good.
You know, I am proud of my students. They are doing a really good job, and we do actually sometimes have the teleconferencing meeting from all the parallel healthcare, the doctors, and see how they are, you know, what protocol they are following, whether we can refine it, how everything is. You know, we have a mutual, that type of a support system.
And I definitely get the vibe from all the other anesthetists that they have tremendous respect for you, as well as their professor, and they always turn to you.
And they are doing a very good job, and we will have to continue the good job. But I will implore our common public, please follow public health guidelines. Please go and vaccinate. I know that vaccine hesitancy is still there, but science supports vaccine, and that is how we can prevent people getting into ICU and give some break for my students.
All right, Professor, thank you so much for coming back on the program again today.
Thank you.
We really appreciate it. Thank you for your good work in the ICUs. I mean, you were on call last night and you're here today. Thank you so much for that.
Thank you for your...
So all our viewers at home, thank you for joining in. I hope you enjoyed the program tonight. I hope you learned a lot. Next week, we're going to do a little bit of pediatrics. So to all those attending messages, I'm sorry we didn't get to all your questions, but thank you so much for everything. Everyone, please have a pleasant evening. God bless. Take care. We'll see you next week.